Finals SAQ22 Awareness During General Anesthesia. Introduction. NAP5 is a recent publication that is of real-world importance. Some key statistics. Incidence of accidental awareness in GA, AAGA, is 1 in 19,000. Incidence of AAGA if neuromuscular blockers are used, 1 in 8,000. Incidence of AAGA if no neuromuscular blockers are used, 1 in 36,000. Incidence of AAGA in obstetrics, 1 in 670. Incidence of AAGA in cardiothoracic surgery, 1 in 8,600. A. Define the types of unintentional awareness that may occur during GA. These may be explicit awareness or implicit awareness. In explicit awareness, there is spontaneous or prompted recall of intraoperative events. This may occur with or without pain, and may result in psychological harm, sleep disturbance, nightmares, anxiety, and PTSD. In implicit awareness, there is some degree of cortical perception and no conscious recall, but may affect behavior and performance in the future. B. What factors may increase the likelihood of intraoperative awareness? Summary of NAP5 report. Causes includes drug factors such as neuromuscular blockers, thiopental and Tiva. Patient factors includes female gender, young adults, obesity, previous AAGA and difficult airway. Surgical factors includes obstetric, cardiac, thoracic and neurosurgical surgery. Organizational factors includes emergency surgery, junior anesthetist and out-of-hours operating. Drug factors. Tiva results in a full range of human or equipment error issues such as blocked cannula, pump failure, failure to switch the pump on, pump wrongly programmed, etc. Use of neuromuscular blockers. 97% of episodes of awareness reported to NAP5 included use of neuromuscular blockers. Causes includes failure to reverse, failure to monitor depth of block, human error causing syringe switches, failure to label syringes properly, and mixed up ampules. Thiopental use is associated with increased incidence of awareness. RSI is also associated with AAGA. Patient factors are as mentioned, which includes female gender, young adults, difficult airway, obesity, leading to difficulties with drug dosing and risk of difficult airway, previous awareness, indicating possible genetic component, sick and cardiovascularly compromised patients, leads to lower doses of anesthetic agents given. Surgical factors. Obstetric surgery, especially emergency Caesar, due to anxiety, no pre-medication, physiological changes of pregnancy mass awareness, neuromuscular blocker use, thiopental use, potential underdosing due to failure to account for body weight, rapid sequence induction, emergency situation with risk of drug errors, junior anesthetist, out of office hours, short period between intubation and commencement of surgery, not giving adequate time for drugs to work. Failed regional is a risk factor according to report submitted. Cardiac surgery. There are not many cases reported in NAP5, but previously high level of awareness reported at the start of cardiopulmonary bypass. This may also relate to cardiac anesthesia technique involving low hypnotic dose and high opioid dose. Accidental awareness may be less likely to be reported as patients are warned of waking in cardiac ICU with tube still in situ, and older patients may possibly be more tolerant. In thoracic surgery, neuromuscular blockers are usually used. Switching tubes from single lumen to double lumen and failing to maintain anesthesia by volatile technique increases risk of awareness. During rigid bronchoscopy, there are episodes of intense stimulation, intermittent interruption to anesthesia administration if volatile anesthetic used, and neuromuscular blocker use all increase the risk of awareness. What monitoring technique can be employed to reduce the risk of awareness during GA? Clinical monitoring includes presence of anesthetist throughout the case, eye position, pupillary dilation, and reactivity to light, sweating, lacrimation, tachypnea, movement, and retching on the tube or LMA may indicate awareness. General monitoring, full equipment checks and ongoing monitoring during anesthesia, including pumps, anesthetic machine and vaporizers, heart rate, respiratory rate and tidal volume, if not paralyzed, and blood pressure. End-tidal anesthetic gas monitoring, TIVA pump effect site or plasma site concentration, train of 4 monitoring to ensure neuromuscular blockade is reversible before the end of anesthesia. Specific depth of anesthesia monitoring, processed EEG converts brain signals into a dimensionless number to indicate range of depth of anesthesia. This includes BIS, where target 40 to 60 for absence of post-operative recall, E-entropy, target value for response entropy for GA is 40 to 60, and narcotrend, target for GA is around 40 to 60 as well. Other specific monitors use auditory evoked potentials as a measure of depth of anesthesia. Additional information. What is the Brice protocol? This is a post-anesthesia questionnaire used by anesthetists to detect awareness based on the study by Brice et al. In 1970. Timing of questioning includes on waking, in the following 24 to 48 hours, and after 2 to 3 weeks. It consists of 5 questions, which are: what was the last thing you remember before going to sleep? What is the first thing you remember on waking up? Can you remember anything in between? Did you dream during the procedure? What was the worst thing about your operation? What are the causes of AAGA? This includes equipment and apparatus failure to deliver adequate anesthetic, such as faulty or empty vaporizer, leaking breathing system, inadequate fresh gas flow, faulty TIVA syringe driver, occluded infusion tubing, and misplaced venous cannula. Failure of anesthetists to use the equipment properly also leads to accidental awareness. For example, inadequate fresh gas flow while using a circle system during initial 15 minutes post-induction. Failure to monitor the concentrations of inspired and expired volatile agents increases the risk of awareness. TIVA is more difficult to monitor because the effect site concentrations are calculated rather than measured. Pharmacological causes. Dose of induction agent may be inadequate for that patient, as may be alveolar concentration or computed blood concentration in target controlled infusion. Awareness is not prevented by hyperventilation, use of nitrous oxide and oxygen alone, and opioids. Muscle relaxants should not be used as hypnotics. Anesthesia should be continued until the effects of neuromuscular blockade have been reversed in full. Physiological causes. Rarely a patient may be resistant to anesthetic agents. Possible risk factors include alcohol abuse, high anxiety, drug of abuse, and moribund patient that adequate anesthesia is incompatible with maintaining hemodynamic stability. The anesthetist should be alert to clinical signs indicating inadequate anesthesia. Airway problems and bronchoscopy. During difficult intubation, the effects of the induction agent may wear off before those of the muscle relaxant. Patient is also at risk of AAGA during some anesthetic techniques for rigid bronchoscopy, such as those using insufflation or injectors. Cardiac bypass increases the risk of accidental awareness. What are the possible consequences to the patient after an episode of accidental awareness under GA? There may be immediate, delayed, or no recall. Experiences may be auditory or tactile, and may include pain and awareness of paralysis. Response is varied. There may be neutral feelings or extreme distress at the time of accidental awareness, which may lead to post-traumatic stress disorder with flashbacks, anxiety, depression, impact on personal, social, and work functioning. The patient may avoid all medical settings, or specifically anesthesia, with loss of trust to healthcare professionals. No recall may still cause long-term problems such as unexplained anxiety due to implicit memory. Patients tend to benefit from explanation and cognitive behavioral therapy. What are the methods to prevent accidental awareness during GA? Measures during pre-operative period and during induction includes evaluation for risk factors of AAGA. If present, consider increasing administered anesthetic dose if it is safe, or regional anesthesia. Consider administering a benzodiazepine as an amnesic pre-medication. Check out equipments, drugs, and dosages are functioning as intended and used as intended. Ensure all drugs are clearly labeled and infusions run into patent veins. Redose IV anesthetics when delivery of inhalational anesthesia is difficult, for example during long difficult intubation process or rigid bronchoscopy. Intraoperative measures: avoid administration of muscle relaxants whenever possible. If neuromuscular blockade are necessary, use the minimum dose necessary. Monitor degree of neuromuscular blockade with peripheral nerve stimulator and assess the adequacy of reversal, ensuring adequate hypnosis until neuromuscular blockade reversal has been complete. Administer at least 0.7 MAC of the inhalational anesthetic agent. Set an alarm for low anesthetic gas concentration. Ensure adequate analgesia. For TIVA, ensure that settings are correct. Target controlled infusion machine and infusion tubing are not faulty. Dedicated patent IV cannula is used for TIVA and is visible to be assessed intraoperatively. Consider depth of anesthesia monitoring.